Welcome to the weekly Neurology Deep Dive. This program is produced by Amerigo.
Right, and just right off the bat, we want to state clearly that this audio is provided solely for educational purposes.
Exactly. There are absolutely no commercial goals here.
None at all. And, this is strictly a summary, so we highly recommend that you read the full paper we're discussing today to inform your daily clinical practice.
For sure. Definitely read the full paper.
Yeah.
So, what if the diagnostic tool you use to hunt for vasculitis is actually, well, dictating the disease you find?
Yeah, that's the big question, isn't it?
It really is. Today, we're doing a deep dive into a paper titled Inside the Heterogeneity of Primary Central Nervous System Vasculitis, a single-center 40-year experience.
Which was by Carlos Alvarani and colleagues, published in 2026.
Right. And before we get into the weeds of the data, could you give us an upfront practical summary for daily clinical practice?
Absolutely. So for your practice, the main takeaway is that primary central nervous system vasculitis is, it's not a single entity. It's a highly heterogeneous disease, and you really have to divide it by vessel size and histopathology.
Makes sense.
Small vessel involvement, which you'd typically diagnose via biopsy, that presents more often with cognitive dysfunction, meningeal enhancement, and cerebrospinal fluid abnormalities.
But it actually has a better treatment response, right?
It does, yes. Conversely, medium and large vessel involvement, usually diagnosed via angiography, presents with strokes and persistent deficits.
Okay. And what about the treatment implications?
A major clinical takeaway is that adding aspirin, particularly in that medium and large vessel disease, helps prevent rapid progression and aids in long-term remission.
Wow. Okay. So our mission today is to unpack the data from this massive 216-patient, 40-year Mayo Clinic cohort.
A huge data set.
Yeah, really massive. And the goal is to help you better subtype patients and, tailor your initial immunosuppressive and antithrombotic therapies.
Exactly. And we really need to start by looking at how the cohort was diagnosed.
Because the diagnostic tool inherently acts as a proxy for the size of the vessels involved. Right.
Precisely. So the paper breaks down these 216 patients, and the median age was 49 years.
Okay.
Out of that group, 142 were diagnosed by cerebral angiography, which represents medium and large vessel involvement.
And the rest?
The remaining 74 were diagnosed histologically by biopsy or autopsy, representing small vessel involvement.
But here's my question. If we rely on angiography versus biopsy, are we actually capturing different disease phenotypes?
Or just looking at the same disease through different diagnostic lenses.
Exactly. I mean, a standard biopsy captures such a tiny sample.
Right. The authors looked at this, and the data actually confirms distinct phenotypes. It's not just a diagnostic artifact.
Right, really?
Yeah. The biopsy group, so the small vessel group, had significantly more cognitive dysfunction, gadolinium-enhanced parenchymal and meningeal MRI lesions, and elevated cerebrospinal fluid protein.
Oh, wow. And the angiography group?
They had significantly more persistent neurologic deficits and MRI evidence of infarcts.
That's a stark contrast.
It gets more interesting. Non-inflammatory cerebrospinal fluid was found in about 23% of the angiography group.
Compared to what in the biopsy group?
Only about 8%. That's a significant difference.
So, because the diagnostic method implies different vessel sizes, we really must isolate these groups, right? To truly cement this subtyping.
Yeah, exactly. To see how it alters clinical presentation, the authors compared the 21 patients with strictly isolated small vessel involvement against the 31 patients with isolated medium and large vessel involvement.
Okay, let's hear the numbers.
Isolated small vessel disease was significantly and positively associated with mass lesion presentation, with an odds ratio of about 19.
About 19. That's huge.
And meningeal enhancing lesions, an odds ratio of about 39.
Wow.
Plus, beta amyloid vascular deposits had an odds ratio of about 23.
But what about strokes?
It was significantly negatively associated with cerebral infarcts, an odds ratio of roughly 0.2.
So they basically don't stroke out. But what about the patients who had both small and medium and large vessel involvement?
The dual involvement cases.
Yeah, does having both just look like a sum of the parts, or is it, a uniquely aggressive variant?
It's uniquely aggressive. The paper details 9 patients with dual involvement, and they had a much more severe and inflammatory disease course.
How severe are we talking?
Well, their erythrocyte sedimentation rate median was 26 millimeters per hour.
Oh, wow. For a primary central nervous system condition, that's really high.
Yeah. And cerebral infarctions were present in about 89% of these patients.
Almost all of them.
Right. And sadly, they suffered a high mortality rate of about 56%.
About 56%. That's just devastating.
It really is.
Okay, so Having established the distinct clinical features of vessel size, we need to move to the microscopic level.
The histopathological patterns.
Right. Among the histologically diagnosed patients, does the specific type of cellular inflammation dictate the patient's prognosis?
It definitely does. The paper breaks down the 71 evaluated biopsy cases. There were 43 with granulomatous vasculitis, 10 with necrotizing vasculitis, and 17 with lymphocytic vasculitis.
Got it.
And just to note, 24 patients in that mix had amyloid beta-related angiitis.
Wait, I noticed a seeming paradox in the data here.
Which is?
The data shows that lymphocytic vasculitis had a significantly longer interval from symptom onset to diagnosis.
Right, it did.
Logically, wouldn't a delay in diagnosis lead to worse outcomes for those patients, since the inflammation is just sitting there?
You would think so, but despite the delay, lymphocytic vasculitis is actually the most benign phenotype.
Really? How so?
It was associated with a significantly younger median age at diagnosis, 34 years, and they had more seizures, but significantly lower disability and 0 deaths.
0 deaths. That's incredible.
Okay.
What about the necrotizing variant?
That's a different story. Necrotizing vasculitis was significantly linked to intracranial hemorrhage. It was seen in about 30% of those cases.
About 30%. That's a massive risk.
Yeah. Furthermore, when they grouped granulomatous and necrotizing vasculitis together, there was a significant positive association with severe disability at the last follow-up.
So the cellular infiltrate type really does dictate the trajectory.
Absolutely.
Okay, so we now need to connect these anatomical and pathological phenotypes directly to daily clinical management.
Right, focusing on therapy response, relapse rates, and long-term prognosis.
Let's start with the overall response. How did the cohort do?
Overall, about 83% of patients responded to therapy.
That sounds good initially.
It does, but only about 24% achieved long-term remission, which they strictly define as at least 1 year of inactive disease off all therapy.
Ooh, only about 24%. That's quite low.
Yeah, and about 13% of patients had a rapidly progressive course.
What drove that rapid progression?
It was linked significantly to older age, cognitive dysfunction, and cerebral infarctions. And the mortality for the whole cohort was about 21%.
Okay, and what about relapses? How common is a relapsing course?
A relapsing course meaning 2 or more relapses occurred in about 13% of patients.
Was that associated with a specific subtype?
Yes, it was significantly associated with having a histologic diagnosis, so small vessel disease.
That's interesting. The group that responds better initially is actually more prone to relapsing.
Exactly. However, the angiography group, the medium and large vessel patients, they had significantly higher rates of aspirin use.
How much higher?
About 42% versus about 12% in the biopsy group.
Oh, wow. Big difference. Did the aspirin help?
Significantly, aspirin therapy was positively associated with long-term remission, with an odds ratio of nearly 3.
An odds ratio of nearly 3.
Yeah, and it was protective against a rapidly progressive course.
Okay, but here's a very practical safety concern for neurologists listening right now.
What's that?
If aspirin is so protective, does the presence of cerebral amyloid angiopathy in biopsy-positive patients contraindicate its use?
Due to the risk of intracranial hemorrhage.
Right. I mean, you've got brittle vessels.
The paper specifically evaluated this. They found no significant difference in aspirin use between biopsy-positive patients with and without cerebral amyloid angiopathy.
Really? So clinicians weren't avoiding it?
Nope. And the paper actually aligns with European Stroke Organization guidelines.
What do they recommend?
They recommend aspirin be initiated primarily in patients with medium and large vessel involvement, alongside immunosuppression like glucocorticoids and cyclophosphamide.
And that doesn't cause a spike in bleeds.
It improves long-term outcomes without a distinctly increased hemorrhage risk.
That is highly actionable for daily clinical practice.
It really is.
Okay, so let's repeat the core practical summary to synthesize this data and leave you with a clear framework for your next clinical encounter.
Perfect. So again, primary central nervous system vasculitis must be subtyped by vessel size and histopathology.
Right.
Small vessel disease features cognitive issues and MRI enhancement, but responds better to therapy.
Whereas medium and large vessel disease is marked by infarcts and persistent deficits.
Exactly. Crucially, early identification of high-risk patients and the addition of aspirin for medium and large vessel disease can prevent rapid progression and improve long-term remission.
Which brings up a really provocative thought to end on.
Let's hear it.
If primary central nervous system vasculitis presents with such drastically different symptomology, imaging findings, and mortality rates based purely on vessel size and cellular histology,
Yeah.
Will future diagnostic manuals eventually abandon this umbrella term altogether?
That's a great question.
Right? I mean, maybe they'll reclassify these as entirely distinct, separately named neuroinflammatory diseases. Something for you to ponder.
It certainly seems headed that way.
Well, thank you for joining this week's Weekly Neurology Deep Dive. And we remind you once again to please read the full paper for your clinical practice.